Hello and welcome. I'm Susan Denser, a member of the advisory board of the Duke Margolis Center for Health Policy, and I'm also the president and chief executive officer of America's Physician Groups. I'm very pleased to serve today as the opening moderator of this session, and I really want to thank all of you who are listening in and participating today. Our purpose is to share results and policy recommendations that have emerged from a recent Duke Margolis research project called Exploring Equitable Access to Care and Outcomes Using Telehealth in the Transition to Medicaid Managed Care. This study was funded through a generous grant from the Kate B. Reynolds Charitable Trust, and we want to thank the trust for its all-important support that made this research project possible. I invite attendees today to join us in tweeting about the event or otherwise making the world known about it on social media using the hashtag #MargolisMedicaid. Next, a few housekeeping items. Another way you can take part in the conversation today is to participate in the question and answer function. Just put a question if you have one in that Q&A function, which can be found on the Zoom toolbar, next to the chat function. We've structured the virtual town hall to be very, very interactive. So please don't hesitate to use that Q&A function. We're recording this meeting, and that recording will be posted to the Margolis Center website, on the event page of that website. So here's the agenda for today. Before we start, we want to offer a special acknowledgement to the two people who led this study. First, the principal investigator, Dr. Janet Prue-Becker, associate professor in orthopedic surgery at Duke University, and core faculty member of the Margolis Center for Health Policy. We also want to acknowledge the study co-lead, Dr. Rebecca Whitaker, assistant research director at the Margolis Center. And with that, Rebecca, and the audience having had a chance to glance through that agenda, let me turn it over to you to give us a preview of the key takeaways and the recommendations from this research. Rebecca?
Great, thank you so much, Susan. We started this project because we wanted to know whether telehealth created more opportunities for people to access the healthcare services they need, when and how they need those services. We were especially interested in understanding whether telehealth helped people access healthcare who have historically faced greater barriers to receiving health services. We want to frame today's town hall by sharing our key takeaways and recommendations from our research to date. My colleagues are going to talk in more detail about these findings. Our main takeaways are that 1, telehealth certainly helped people access healthcare during the COVID-19 pandemic, and can be integrated into clinical practice going forward. However, telehealth has not yet closed the gap in getting care to groups that have been historically marginalized, especially people of color. In other words, telehealth did not eliminate barriers to accessing care for all groups. In fact, about 64% of healthcare providers we surveyed believe that differences in telehealth use are due to factors such as race, culture, English proficiency, literacy, and clinical conditions. Even so, and if we go on to the next slide, we believe that telehealth should be integrated long-term into the Medicaid program and strategies devised that will increase equitable access to care using telehealth. In particular, we suggest that Medicaid agencies carefully consider the role that audio-only telehealth plays in expanding access to care for historically marginalized groups. For those who aren't familiar, audio-only telehealth is when people talk with their healthcare provider in real time, but without a video. Our research showed that while audio-only telehealth was not frequently used overall, certain groups of patients did use audio-only services more. And we see this corroborated in other research as well, including in our recent RAND study of federally qualified health centers that found audio-only use was commonly used for the patients accessing care in these health centers. Finally, payment model design can facilitate more equitable and high-value application of telehealth. We heard a lot of concerns from healthcare providers about the payment amount and the permanency of payment for telehealth in Medicaid and across other health plans. We know that the way we pay providers really matters, and we can pay providers in such a way that better integrates telehealth into the long-term provision of high-value health services. With that, I'm now going to turn to Dr. Shannon Dowler, the Chief Medical Officer for North Carolina Medicaid, to provide some opening remarks for this town hall. Shannon and her team, especially Dr. Emma Sando and Sam Thompson, have been critical partners in helping us ensure our research is timely and policy relevant. Dr. Dowler joined the North Carolina Department of Health and Human Services, or NCDHHS, as the Chief Medical Officer for North Carolina Medicaid in 2019, though her involvement with the department began many years prior. She's leading efforts across NCDHHS related to telehealth and health equity, most recently with a focus on increasing COVID-19 testing and vaccinations in historically marginalized populations. Prior to joining NCDHHS, Shannon held leadership roles in a public health department, a large federally qualified health center, and a mid-sized health system in Western North Carolina. A dedicated public servant and healthcare advocate, we are so lucky to have her join us today. So with that, over to you, Dr. Dowler.
Thanks so much. I appreciate having the opportunity to reflect for a couple minutes on our journey at Medicaid. As an important world leader once said, what a long, strange trip it's been. Sometimes government is accused of moving at a snail's pace. It's hard to believe that just 2 years ago, almost overnight, North Carolina Medicaid went from having one very limited telehealth policy, distant site only for psychiatric consultation, to literally hundreds of new codes, services, and opportunities to lean into the digital age. Our team can attest to our new definition of a snail's pace. From the first day we launched this rapid modernization, we were already lamenting the day when the magic genie that was being released in the public health emergency would have to be put back in the bottle. We struggled whether we should even turn on access, knowing how painful it would be to take it away. But we determined that with the baseline approaching zero telehealth offerings, this was the perfect opportunity to learn, and we committed to study and seek to understand the impact of these new services. From the perspective of the beneficiaries, the providers, quality of care, health outcomes, health equity, and payment integrity. Under the leadership of Sam Thompson and with support from CCNC and the Shep Center, our evaluation plan was launched simultaneously with the first coverage changes. And we have 2 years of data now that we've scrutinized and puzzled over, representing the care of almost 2.8 million beneficiaries. We've surveyed providers and beneficiaries alike for their qualitative feedback. We have treasure troves of data on utilization, cost, access, and equity. But be careful what you ask for. Now we have even more questions than answers. Why didn't we see access improve for historically marginalized populations? 2 years in, and the odds of using telehealth remain higher for white, non-Hispanic, and urban beneficiaries. Why, even though telehealth was supposed to be a boon for rural areas, is utilization focused in the urban areas? Despite sweeping broadband initiatives and free community Wi-Fi being extended into remote corners of the state, our rural areas are still missing out. At my house on the side of a mountain in Madison County, prior to broadband coming in about a year ago, my neighbors used to have to get out their four-wheeler, drive to the top of the cow pasture to get enough signal to upload their first graders' homework on their cell phones. Today, they do it comfortably from their house in the holler. But the questions remain. What will the long-term outcomes be for populations with the majority of their care provided virtually? Given the majority of telehealth users were already engaged in care, how can this technology better reach the disengaged to create meaningful access? And what is the long-term impact of virtual care for populations with limited health or technology literacy? Case in point, my mom, who is approaching 80, this is not a picture of her, had a telehealth visit recently. And at the end of the visit, the doctor recommended she Google her diagnosis and pull up some diets she might try to alleviate her symptoms. She called me a week later, not feeling any better, wanting to know what to do. I asked her if she tried the diet changes, and she confessed she was so confused by everything she found on the internet, most of it conflicting, that she didn't know what to do. So by not being in person, what opportunities for patient education and service are we missing? Probably the hardest question from the payer perspective is, how do you maintain payment integrity when the definitions, permissions, and flexibilities hang in the balance from one day to the next, and the absence of nationally agreed upon standards, terminology, and permanent guidance? How do we work together for progress without overshooting our targets or missing them altogether? Mission critical is real-time study and seeking to understand from our experience. if you take investments, it's going to take us investments of time and money and objective, non-biased or conflicted brains for all of us to sort through the data, to understand the implications, and to establish the new standard of healthcare in the advent of telehealth modernization. As a public payer, the four main questions I'm continually seeking to understand are these. How do we create access while honoring the highest integrity care so that we don't inadvertently create new health disparities by providing a lower level or less effective care to those who already have fewer resources? How can we engage technology to achieve the quadruple aim, respecting that not all people show up at the table with the same degree of health, spoken, and written literacy? How do we safeguard the medical home to ensure that care is not fragmented, redundant, and otherwise disrupted in our zeal to appeal to consumerism? And finally, how do we determine how the broad array of services we now have at our fingertips is creating meaningful improvements over baseline, not just in patient and provider experience, but in health outcomes and total cost of care? I'm so grateful for Duke Margolis and the KB Reynolds Charitable Trust for creating this opportunity for study and learning. And I think you're going to find the data they present today intriguing. It is one more step on the journey to clarity. Thanks so much.
Well, thank you so much, Dr. Dowler, and thank you for enumerating those incredibly important public policy questions that the department faces and that, in fact, the entire nation's healthcare sector faces now as we work our way forward, not just during the public health emergency, but obviously when it ends, and whether it's going to be possible or even desirable to put that genie back in the bottle, as you said so memorably a few moments ago. I now have the pleasure of introducing Samantha Repka, who's the research associate at the Duke Margolis Center for Health Policy, and Sam is going to provide the policy context and the study overview first. So Sam, over to you now.
Great, thank you so much, Susan. Before I give that brief overview of our study, I want to define a few key terms we're going to be using today throughout the town hall. So the first is, when we say equitable access to healthcare, we mean that everyone has a fair and just opportunity to access the health services they need to be healthy when and how they need those services. Second, when we say telehealth, which can also be referred to as telemedicine, we mean a healthcare visit with a physician or other healthcare provider that occurs without an in-person visit. This can include both audio and video visits provided using a computer or a cell phone. And as you heard from Dr. Dowler, the COVID-19 pandemic really led to this rapid shift to delivering many healthcare services remotely in order to reduce exposure and maintain access to healthcare for patients. For our research team, this was really an opportunity to study and try to understand, for people enrolled in Medicaid in North Carolina, who was able to access services via telehealth during the pandemic. Were there disparities or differences in access to care for certain groups of people? And what policies and supports are needed if telehealth were to expand as one approach to delivering high quality healthcare? So with that in mind, for our research, we took a look, and if we could go to the next slide. We took a look at two common health conditions. We looked at behavioral health conditions, such as anxiety, depression, and schizophrenia. We also looked at musculoskeletal, or MSK conditions, such as low back, hip, knee, and shoulder pain. These conditions are highly prevalent among people enrolled in Medicaid and two of the leading sources of disability in the United States. We also chose these conditions because they have natural differences in how telehealth might be applied to service delivery. Pre-pandemic, we know that telehealth was already being used to deliver many behavioral health services effectively for therapy and certain other applications. On the other hand, telehealth was not commonly used for MSK services pre-pandemic. And the nature of MSK services in addressing the physical needs of individuals required further adaptation by providers to make that transition to telehealth. For both, we think there are lessons learned and policy implications for coverage and care delivery moving forward. So that leads us into our two study goals. First, we'd really like to understand whether telehealth has helped Medicaid enrollees with behavioral health, MSK, or both conditions access the health care they need. Second, we want to identify whether there are disparities in access to services that telehealth could, in access to care via telehealth, that could be addressed with clinical and state level policy reform. So now I'm going to give a quick overview of how our study was designed and some of our methods, which we're using to really explore the goals we just mentioned. So we're using two approaches. One, we're looking at healthcare claims data. And claims data are requests that healthcare providers submit to insurance companies, in this case to Medicaid, for payment. So using healthcare claims data, we looked at use of behavioral health and MSK services a bit differently, and you'll see that highlighted here on the chart. For behavioral health, we looked at people who were already using behavioral health services prior to the pandemic, which we define as March 2019 through February 2020. We then looked at who continued to access services, whether that was via telehealth or in person during the pandemic, which we define as April 2020 through March 2021. Someone was defined as a telehealth user for this study if they received one or more behavioral health services via telehealth visit during COVID. So for musculoskeletal conditions, we focused only on the COVID time period, and we looked at individuals with an MSK diagnosis who received one or more health services from an MSK provider. We defined someone as a telehealth user in this group if they had an MSK diagnosis and received one or more health services via telehealth with an MSK provider. And you can see on that table had the number of individuals that were included in our study. So the adults and youth enrolled in Medicaid included in our research received their behavioral health care or MSK services from a variety of healthcare providers that you can see on this slide. Just to highlight a few examples, for behavioral health, you have psychiatrists, licensed clinical social workers. For MSK, you have physical therapists and occupational therapists. And providers like primary care physicians and nurse practitioners could provide both MSK and behavioral health services. We identified behavioral health. And so in addition to looking at healthcare claims, we also conducted direct outreach to some of those providers you saw on the last slide. And what we're doing is we're adding to our understanding and what we're seeing within healthcare claims data by having conversations with key stakeholders. So we're using surveys, interviews, focus groups with individuals who are enrolled in Medicaid, their caregivers, and healthcare providers mentioned on the last slide. That work is still ongoing, and I want to actually highlight one area where we're looking for additional input. We're still collecting responses on a survey where we're asking North Carolina providers about their experiences delivering services via telehealth. We're especially interested in hearing from more physicians and advanced practice providers who are delivering musculoskeletal services. So folks who are specializing in pain medicine, orthopedics, rehab, and sports medicine. We'll include a link to that survey in our follow-up email next week in case you have relevant colleagues or providers in your networks and would be willing to share. And thank you in advance. So with that, I'd now like to move into our research presentations. And before I introduce our first presenter, I want to acknowledge the broader research team who contributed to this work, including the core staff, faculty, clinicians, and students. This work wouldn't be possible without this wonderful interdisciplinary team. So you'll now hear two short research presentations, each followed by a question and answer period. We'll take your questions and comments via the Q&A function, which can be found in your Zoom toolbar. After that, we will have two moderated panels with our invited panelists, so we invite you to stick around. I'd now like to introduce our first presenter, Dr. Rushina Cholera, Assistant Professor in the Duke University Department of Pediatrics and core faculty member at the Duke Margolis Center for Health Policy. Dr. Cholera will share findings on access and maintenance of care via telehealth among Medicaid beneficiaries with behavioral health conditions. With that, Dr. Cholera, I'll turn it over to you.
Thanks so much. I'm really excited to see everyone here this morning. So as Samantha said, I'm a pediatrician and health services researcher here at Duke. And I'm going to spend the next few minutes telling you a little bit more about our findings amongst people with behavioral health conditions. Next slide. So I'll start with a little bit more context to build on what you've already heard. Behavioral health conditions are very common among both adults and children, but I want to highlight that even before the pandemic, at least 1 in 5 adults, as you see at the top of the slide, and 1 in 6 youth had a documented behavioral health condition. And I think as we've all heard in the news, these conditions became much more prevalent during the pandemic. So during the pandemic, the prevalence of both depression and anxiety doubled. And that prompted the declaration of a behavioral health emergency. And that was true from multiple national organizations. So as a pediatrician, I've seen this firsthand over the last couple of years as the number of children I've taken care of personally with behavioral health conditions or in crisis has drastically increased. Now here in North Carolina, the high demand for behavioral health services during the pandemic has stressed what was already a fragmented and under-resourced mental health system. And as you can see highlighted in the headline at the bottom of the slide here, last year, hospitals and health systems across the state called on our state leaders for emergency help in the context of this emergency. Now you've heard already from both Samantha and from Susan earlier in the presentation that telehealth use for behavioral health conditions was already happening even before the pandemic. Now, in the context of the pandemic, what we've seen is a quite dramatic increase in the use of telehealth, but what we don't know is how, and what we've sought to understand is how the use of telehealth for people with behavioral health conditions has changed or how access to care has been affected. So this slide shows how behavioral health telehealth use was distributed across North Carolina. On these maps of North Carolina, on the left, you see the percent of youth, and on the right, you see the percent of adults, again, with existing behavioral health conditions, even before the pandemic, who became telehealth users during the pandemic. Lighter colors represent fewer telehealth users, and darker colors represent an increased percentage of telehealth users in a given county. So as you can see, the percent of telehealth users varies quite a lot by North Carolina county. And overall, just comparing the two maps visually, you can see that youth, or again, people aged 20 or younger, were generally more likely to use telehealth for behavioral health services as compared to adults. And I'll also note that the majority of the utilization we see here was telehealth video visits. Overall, we really did not find that audio-only services were very common for behavioral health. However, there are a couple of exceptions to that. Namely, we found that American Indian or Alaskan Native groups, as well as rural beneficiaries, had more audio-only visits. And I think that gets at some of the important nuances we've already heard about around things like access to broadband internet in some groups. Next slide. So next, we looked at how people with existing behavioral health conditions tended to access services during the pandemic. So as stated at the top of the slide here, we found overall that a higher proportion of youth with increased medical or behavioral health complexity used telehealth to access care during the pandemic. But let me orient you to this slide. So on the vertical axis, what you see is different groups of youth Medicaid beneficiaries. The top two are Medicaid eligibility categories. So the general pediatrics category is going to include the vast majority of children, while the blind and disabled category includes kids with substantial medical complexity. Under that, we have two other groups. So children who are eligible for the North Carolina Medicaid Tailored Plan, which will launch later this year, and includes those with significant behavioral health needs and intellectual or developmental disabilities, or what we're calling increased behavioral health complexity here. So on the horizontal axis, you have the percent of beneficiaries broken down by how behavioral health services were accessed during the pandemic in the different colors. So in the top category for youth in the general pediatrics Medicaid eligibility category, so that's the top bar that you see on the slide, you can see that 37% of youth in this category accessed behavioral health services via telehealth during the pandemic. 30% received in-person behavioral health services only, as you see in blue. And then 33% who again had behavioral health conditions before the pandemic, did not receive any behavioral health services at all during the pandemic. What I want to highlight is what you see in purple. So you can see, again, the purple is those who did use telehealth during the pandemic. We find overall a much larger proportion of beneficiaries with increased medical or behavioral health complexity. So those in the blind and disabled group, or those eligible for the tailored plan group. Those two groups were much more likely to use telehealth to continue access to care during the pandemic. Lastly, I just want to note that while we've only shown results for youth here, we found very similar patterns amongst adults as well. Next slide. So this slide is focused on comparing behavioral health service use for youth who were telehealth users during the pandemic compared to those who were not telehealth users during the pandemic. What we're showing here is how these two groups used behavioral health services before the pandemic as well as during the pandemic. So on the left in the red box, you can see that for those youth with behavioral health conditions who used telehealth during the pandemic, there was a minimal % change in access to care for both medical management of behavioral health conditions in the top row, as well as for psychotherapy. However, on the right, again, in the red box, you see that for those who did not use telehealth during the pandemic, there was a substantial decrease in for both of these service types, the medical management as well as psychotherapy, in the proportion of beneficiaries who accessed behavioral health care during the pandemic. So overall, what this means is that a much larger proportion of telehealth users were already engaged in care and accessing services prior to the pandemic. And telehealth helped this group maintain access to care during the COVID-19 pandemic. Next slide. This slide really shows the same analysis for adults, so I won't spend much time here. What I want to point out here is that you can really see the same patterns held true for adult beneficiaries as well. In particular, that the % already accessing services before the pandemic was much higher among those who became telehealth users. Next slide. So the next thing we looked at was how the likelihood of becoming a behavioral health telehealth user varied by different types of patient characteristics. And this really gets to the heart of our question here, and when you think about disparities in different groups. So I want to highlight some of our key findings here. So as you see, we found that both Black youth and adults, you see youth on the left and adults in the right column, as well as those from other races or multiracial groups, or beneficiaries of Hispanic or Latinx ethnicity, youth in particular, were all less likely to become telehealth users compared to white or non-Hispanic beneficiaries. Both females and beneficiaries eligible for tailored plans were more likely to become telehealth users. However, we found no difference in the likelihood of telehealth use by rural residency for either youth or adults. Next slide. So as we wrap up the numbers, or all the quantitative findings, I think these two quotes from some of our qualitative work really bring some of this home for you. So these are quotes from behavioral health providers about their experiences in providing telehealth during the pandemic. And I felt that these really highlighted even my own experiences in doing this work. So first, in the green box, one provider said, "Many families report positive aspects such as easier access to care and comfort of own environment, especially for children with special health care needs and with mental health concerns. They also report that social limitations such as transportation are no longer a barrier." So I think this gets to really how telehealth has been able to expand access for some families. And then in the purple box, telehealth options have dramatically improved access for the Medicaid population my agency serves. My agency or clinic provides mental health and addiction services. While telehealth is a needed option with addiction services, it should not serve as the only option. Face-to-face services need to be incorporated, especially early on in treatment. And I think this really highlights a lot of what we don't know yet. When is telehealth best? When can we really get the best quality of care, and where is that balance? Next slide. So I'll quickly summarize all of our findings for you for this portion of the behavioral health piece. So as you see in the green box, telehealth users we found had both higher service use before the pandemic, so pre-COVID, and higher maintenance of care compared to their non-telehealth user counterparts. And then in blue, people of color, primarily Black or other race beneficiaries, multiracial youth and adults, and then Hispanic youth, were all less likely to become telehealth users. And then lastly, people with more substantial medical or behavioral health complexity were more likely to become telehealth users during the pandemic. Next slide. So what do all these findings mean? Here, we've tried to highlight some of the policy implications and recommendations that we've been able to draw, and I hope we'll hear from some of you during the Q&A about your thoughts on some of this as well. So what we found here is that telehealth can expand access to services during the current behavioral health crisis, and we've seen a dramatic increase in telehealth use. But really, to reach its full potential, we need to focus on strategies that can eliminate some of the barriers to telehealth access, particularly for people who may not have been engaged in care prior. So in terms of recommendations, in the first bullet point you see, we suggest that policymakers can leverage payment and regulatory opportunities to promote the use of telehealth for behavioral health services by patients and clinicians. This is particularly important right now as the state of emergency evolves and as we're seeing a lot of new regulations put in place for telehealth across the country. Second, we need additional research to understand what we've seen here, particularly that people of color, we saw that Hispanic youth as well, were less likely to become telehealth users. So we need to understand why that's the case and be engaging with communities and be engaging in a much more nuanced way to understand what drives those differences and how to mitigate them so that we're not in an unintended way seeing an increase in inequities that already existed. Third, we need strategies to further expand access to telehealth for people with tenuous connections to healthcare to begin with. And this is again what I said at the beginning here. We saw that telehealth helped people who were already engaged in care maintain their care, but we really need strategies to get past that and expand access beyond those who were already engaged with healthcare. And then lastly, we've seen that people with both medical and behavioral complexity were more likely to become telehealth users. And there are, I think, a number of implications for tailored plan implementation later this year in North Carolina. And with that, I want to leave a little bit of time for questions. So thanks so much for listening, and I'm happy to take any questions. And I think you can type those into the chat.
Great. Rashina, thank you so much for that very, very important presentation. And while we wait for any questions to emerge, I'll take the moderator's prerogative of asking the first one. Your results very much track with what Rebecca said the overall takeaways were from all the components of this study, in that there's a good news and a bad news story here. The good news is that clearly telehealth helped maintain access for many Medicaid populations throughout the public health emergency, particularly those who were already using telehealth before the COVID pandemic set in. The bad news is we don't see signs that telehealth greatly reduced disparities in access to care across racial, ethnic, and other lines. So as you think about this as a provider, and as you said earlier, you saw drastic increases in behavioral health needs for the patients you've treated during the pandemic. What do you think will be the most important interventions to reduce the disparities that you described, as well as some of the additional ones that Dr. Dowler mentioned, the fact that there isn't as much telehealth use in rural areas when we really clearly would have thought there would have been more ability to access telehealth services to redress some of that disparity during the course of the pandemic?
Thanks, Susan. It's a great question. I think that there's so much potential for telehealth. And I think that it's all a matter of trying to figure out how we meet families and communities where they are. And what this really gets at is that there are already so many social risk factors. So people, it's not just, getting into clinic that may be an issue. It's, do you have broadband access in your home? It's, do you have somewhere where you can access the internet? Do you have a private space? And so I think starting to really get at beyond describing these disparities that we've now seen, now really engaging at a community level and saying, what are the things that as a system may be helpful to try and provide for families or entire communities to gain access to some of these things. I think there are multiple options, whether it's things like setting up kiosks in private spaces where people can go to access telehealth services. I think, as Dr. Dowler mentioned, some of the broadband initiatives that have popped up and are still, I think going to be a major part of increasing access. I think really getting to some of the root causes of those things will improve, hopefully, the uptake of telehealth more broadly, because I do think there is a lot of potential if used well, but as we've seen here, and I don't, this is consistent with what we hypothesized early on, that some of these disparities were not mitigated by the use of telehealth early on.
Great. Thank you so much, Rashina. And a question has come in. Have you been able to ascertain the impact on quality of care of increased telehealth use during the pandemic? And how do you think we can best tie outcomes to healthcare utilization to really look at the impact on the quality of care? Any thoughts on that?
I love that question, because I think that, as you saw in one of those quotes from the behavioral health providers that we talked to, there are situations I think we heard from multiple folks, and that I also personally feel that where you really need that one-on-one or face-to-face time in person with a family to be able to go beyond what you can do on a screen. And I think not only are there particular conditions that may lend themselves well to telehealth, but even within, as you're seeing here and what we're describing, you'll see, differences in how behavioral health and musculoskeletal conditions have been, how telehealth use has been used for those two very different types of conditions. So there's that, but even in a more nuanced way within behavioral health conditions, for example, there are some particular groups of conditions that providers have felt pretty strongly just can't be treated in the same way via telehealth. And I think there's so much more work to be done to figure out, are we able to still maintain the same quality of care for the same groups? Are we seeing the same thing in children and adults, or even, younger children compared to older children? I think there's much, much more to be done to understand whether quality is able to be maintained with telehealth. But I really think that's where we will be going next as a field. I don't think we know those answers yet.
And as you showed, with the ability of those eligible for, or who will be eligible for, a tailored plan, who are frankly some of those with the most complex behavioral health conditions and needs, the potential to really avail themselves of telehealth as part of an overall strategy, a care strategy, correct? It's not going to be that all care is delivered via telehealth, but it would be a tool that would help maintain continuity of care in addition potentially to face-to-face visits. Would you see that as being the way things are likely to play out, or should?
It's hard to speak to should, but I think that that's certainly what we're seeing already, is that, folks who already are engaged and who have, relationships with providers are much more likely to then be able to transition to maintaining care via telehealth. I suspect that at least for behavioral health conditions and some of the things we see in pediatric primary care, that maybe initial visits will end up being more likely to be in person, and then over time certain conditions can be maintained or treated via telehealth.
Great. So possibly the hybrid world that everyone now is thinking about when it comes to healthcare. Rashina, thank you so much again for a very important part of this presentation today.
Thanks, Susan.
I now have the pleasure of introducing Dr. Catherine Norman, physical therapist and a PhD student with the Duke Department of Population Health Sciences. Pardon me, I just lost access to my notes here, so let me call those back up. Dr. Norman is going to share findings on access to care during COVID-19 for adult and youth Medicaid beneficiaries with musculoskeletal conditions. So Dr. Norman, over to you now.
Thanks. Good morning, everybody. It's still morning for a little bit. So again, my name is Catherine Norman. I'm a physical therapist with a specialty in orthopedics and outpatient, doing my PhD in population health sciences here at Duke. Very excited to talk about telehealth access for people with musculoskeletal or MSK conditions. So with that, we'll go ahead and get started. So just to start off, musculoskeletal conditions, I'm going to call them MSK conditions, are highly prevalent. And especially we see that as people age, we see more prevalence of musculoskeletal conditions. And historically, there's been a lot of barriers to care in MSK services. We see that there's a maldistribution of specialists, therapists, and other providers in urban and suburban settings, and not as many in rural settings, causing a lot of travel, cost for appointments for people kind of in those disparate areas. Additionally, there's various insurance and benefit limitations which further restrict access to MSK services. Limited research to date has shown that telehealth can solve some of these barriers. It has the potential to allow access to some of these people who have travel and cost burden. But so far, there's just been really limited research in MSK services delivered via telehealth, especially because prior to COVID-19, there weren't a lot of telehealth platforms or policies associated with telehealth care. Next slide. So this slide is similar to one that you've seen before, with lighter colors with less telehealth use and darker colors with more telehealth use. You know, we do see that adults were using telehealth a little bit more than youth, especially here in the Triangle area. But so we see that the percent of telehealth users varies widely around North Carolina. Only a handful of counties had high telehealth use for MSK services, and there's even fewer for kids. So good access to MSK services for adults and kids was really, again, in that Triangle area. But otherwise, there's really no consistent overlaps. One thing to point out is audio-only telehealth was the most common among Black beneficiaries and those qualifying for Medicaid based on disability or pregnancy. And so looking at this slide, what we do see is during the pandemic, we saw 6% of youth and 10% of adults with MSK conditions using MSK services, which is low, thinking about it compared to the behavioral health conditions presented previously. But this is actually consistent with what we see with other numbers presented in a national study of telehealth use for MSK conditions. Orthopedists, rehab professionals, some of those traditional MSK providers had really low telehealth conversion rates just because of the novelty of using telehealth. And again, probably the stress of the pandemic. Next slide. So a lot of words on this one, and I think it's important to go over that there are some broad but important socio-demographic characteristics of telehealth for people with MSK conditions. So in youth, the median age of telehealth users was younger. However, we do see that actually telehealth users were older for the adult population. There is less utilization of telehealth among Black youth and Hispanic adults, but we do see that a higher proportion of Hispanic youth are using telehealth services. There were a higher proportion of telehealth users among youth on tailored plan eligible plans, as well as adults on Medicaid due to disability, and those adults with chronic conditions. And again, across the board, what we're seeing is people in urban counties used more MSK services overall as compared to those in rural settings. Next slide. So this is an interesting slide. What we're looking at here is looking at the MSK service use with primary and specialty providers. So that includes anybody who can really write a prescription. So that's not only your primary care physician, nurse practitioners, PAs, specialty providers, including orthopedists, really anyone. So we're looking at those primary care, orthopedic, and other specialty providers. And what we do see is, you know, while there's a similar proportion of adults and youth accessing MSK services, you'll see that green bar on the very left of both charts. It's about 50% of adults and youth are accessing MSK services from primary care providers. We see that telehealth users are actually higher for both groups, especially adults. So what we're seeing is these telehealth users are using healthcare more, and they're using it via telehealth platforms. And the telehealth users exhibited higher access to other healthcare specialists as well. It's not quite as pronounced in the orthopedist conditions, which you'll see in those middle groupings, but over to the far right groupings, we do see that telehealth users are using specialty providers more than the non-telehealth users. Next slide. So this slide is specific to conservative therapists. We separated out physical therapy and occupational therapy, and the conservative therapist includes things like acupuncture, chiropractic, prosthetist, those kind of disciplines. And so right now, just to orient you, just that y-axis is the percent of MSK beneficiaries. And so it is a little bit shorter than the one on the previous slide. We see that the highest that it goes to is about 40%. And so what we're looking at here is a big difference in pediatric beneficiaries who are using conservative therapy via telehealth as compared to adults. Pediatric beneficiaries actually have broader PT/OT coverage services. They've got a little bit more flexibility in what they can be seen for and how long they can be seen for, given the importance of addressing things like developmental delays. They've got teachers and, special counselors at school who are looking out for things that might be of concern, especially with MSK conditions. So there weren't a lot of Medicaid insured children and adolescents who accessed services from occupational therapists and physical therapists from April 2020 through March of 2021. But we do see that when they did access these providers, a lot of them were coming via telehealth services. And most of this was done via virtual telehealth rather than those audio only visits. So they were coming and being seen on video to either go over exercises or really see the therapist for an evaluation. Again, this is important because these rehab providers are critical for making sure that these kids and youth are meeting their developmental milestones so that they can play with their peers and develop into adults with less MSK conditions or less problematic MSK conditions. Next slide. Provider perspectives were an important part of our study. Qualitative research can really add a lot of richness to what we find in some of our quantitative findings. And what we do see is during interviews with MSK providers, they are indicating that telehealth services help to reduce medical waste by improving points of contact and appropriate appointment triage. So you'll see that in that green bubble where one of the MSK providers says, now, with the use of telehealth visits, physical therapy can occur during acute joint and muscle bleeding episode when individuals are experiencing severe pain. For complex medical needs and individuals with bleeding disorders, telehealth is invaluable in preventing multiple in-person medical visits, emergency room visits due to need for clotting factor infusions, and at times hospitalization. Additionally, what we see in the purple bubble is that we see that telehealth was used for rehab purposes. And it helps to create kind of this tailored plan for individuals to understand their personal home environments and promote adherence to home exercise programs. This particular MSK provider in the purple bubble says for rehab professionals, the lens into patients' homes can create a dramatic reality check for providers. Understanding that someone must navigate within and outside of their home will create recommendations that are more practical and likely to improve compliance. So a good exercise program is one that somebody will do, speaking from experience. So we do know that that's important to see somebody's environment and really cater to them. All right, next slide. So just to summarize all the things that we went over and really make sure that we're highlighting some of the important things that we found is that a higher percentage of people from complex groups, especially youth on Taylor Plan eligible and adults with disability or chronic MSK conditions, are using telehealth to access care. While it's low, this is actually, 10 and 6% is a lot higher than 0%, given that we started without really any MSK infrastructure for telehealth. So more complex diagnoses and chronic conditions such as pain, osteoarthritis, and some of those really high burden, low value conditions, telehealth allows for care to happen more frequently. And so this is especially important for providers such as primary care providers and specialists. And these type of patients, the complex patients, usually do require more visits due to the nature of their diagnosis. And this could help reduce greatly their transportation and financial burden. Additionally, the multidisciplinary care teams deliver high-level coordinated care via telehealth. And again, they're meeting people in their homes. For that blue bubble point, the telehealth enabled access for youth needing rehabilitation services and for adults and youth seeking primary care and specialty services for MSK conditions. Again, I can't stress enough, but pediatrics do require a lot of care in order to meet their developmental milestones in order to progress them to more functional adults. And so improving access to specialty care helps to really improve when it may not otherwise be available, especially for patients who might have to travel across county lines because they might not have an orthopedist or a specialist in their county. Critical PT services are necessary for early interventions and developmental milestones. And just to put it in perspective, about 1 in 5 kids use telehealth for physical therapy services, and 1 in 3 kids use telehealth for occupational therapy. And finally, what we do see is there was a higher proportion of white, other race, and multiracial youth using telehealth, but we do see that there continues to be a lack of adoption or use among Black youth who are using telehealth. And so what we do see is there are still some existing disparities in use and adoption, and that definitely deserves a look into as to why that happens and if there are ways that we can really reach these populations. Next slide. All right. And so what we know from the evidence is musculoskeletal conditions, especially complex and chronic conditions, are one of the highest burdens to healthcare. Telehealth services can help to improve the quality of care for patients suffering from these MSK conditions by helping to promote resource allocation across divisions of practicing to reduce low value care. So instead of somebody going to the ER for things like low back pain, they can really see maybe a specialist a little bit earlier so that they don't have to go to an ER where they're not going to get high value care. Especially helping to triage that to maybe PT instead of, again, helping them get an opioid prescription or something worse would be really great, especially given the condition of our health system. And so just looking at all this, our data really supports that telehealth does improve access to specialty and ancillary services, which might reduce avoidable hospital use due to utilization of appropriate care pathways. And then we just need to know more, though, about how to design benefits that we can accommodate telehealth services for addressing MSK issues in the adult population. So this would include things like looking into clinical, regulatory, and payment models to increase telehealth services for those living in rural areas or by populations who have been historically marginalized to really improve healthcare access and quality. And then, we're all sitting here in the waning days, I guess, of pandemic fears, which come and go. But as COVID-19 related policies changes start to expire, there's a lot of uncertainty for providers, patients, healthcare systems about the use of telehealth. And so this can affect how providers, systems, and patients decide to use and integrate telehealth services into their existing practice. So there's a lot of work to be done, but I think it's really exciting and has the potential to really help improve healthcare utilization. I think that's the next slide is, yep. So thank you for your time and attention, and I welcome any questions.
Thank you so much, Catherine. And we do invite those of you with questions to put those into the Q&A function by using the toolbar at the bottom of your screen. So Catherine, what you presented pretty much tracks with the overall conclusions that Rebecca presented and that Dr. Dowler alluded to. And again, as we have seen, good news is telehealth was a very important strategy for allowing a lot of populations to maintain access to care during the pandemic, but it did not close the disparity gaps by any stretch of the imagination, and those continue to exist. And as you pointed out, similar kinds of disparities, much more urban use versus rural use, some differences obviously across racial lines, particularly for Blacks and so on. As a physical therapist yourself, as you look at these findings, and particularly as you showed the one slide that showed the large increase among youth in accessing physical therapy during the pandemic, not so much among adults, right? And we know that many, many adults clearly continue to have those needs during the course of the pandemic. How do you think we can do a better job of addressing that, particularly since it is possible to make a lot of progress and headway with patients, even through virtual physical therapy sessions?
Yeah, that's a great point. And thinking about it, this isn't a field of dreams situation where if you build it, they will come kind of thing. So just because we make these telehealth pathways available, it doesn't mean that we're going to have people adopting this, because we do know that adoption of PTOT is low among adults anyway. There's a lot of coverage differences in pediatrics versus adults. And so, when you think of pediatrics and youth, they were given computer access, they were given internet hotspots, and so that really helped kind of get over some of those broadband access issues of having the technology available. And then also thinking about, these people do have people like counselors at school, and they have more regular visits with their physicians and teachers even, who are helping to facilitate PTOT. You think of the IEPs that are done with schools, especially identifying kids that maybe are falling behind their peers. And so they are facilitated into these PTOT pathways. From a different study, I know here at Duke, we were really adamant about making sure that kids were getting the care that they need. And it's harder for adults. And so thinking about too is like, we do know there's a ton of benefits of conservative therapy for musculoskeletal conditions. And it's, how do we make sure that we're getting people funneled to the right provider, and then making sure that that provider and the way that the care delivery is made available to these patients is something that is attainable. So, similar to what Rashina was saying and what you pointed out, this isn't saying that everybody's going to be on telehealth all the time, but using it as a way to kind of continue care and do check-ins and make sure that people are progressing as they should, to really help improve compliance and adherence, and making sure that people get the care that they need from the provider they need without having to go to places like the ER.
Great. And you mentioned the topic of uncertainty as we are at this stage in the pandemic. Maybe it's over, maybe it's not over. We don't know if the public health emergency will be extended beyond July. As you said, providers don't know what the future holds in terms of payment and coverage around telehealth. What do you think would be most helpful from a public policy standpoint at this point in the pandemic, as we try to create some greater paths to certainty around payment or use of telehealth?
Yeah, that's a great question. And, I think it's, as anything in healthcare, it's really complicated because, we have to make sure that systems are still facilitating the use of telehealth, promoting the use of telehealth and the infrastructure of it, as well as making sure that the policies are in place to promote use of telehealth services. So, it's not there's no magic fix, but making sure that we understand, okay, like MSK services have traditionally never been available via telehealth. What were things that people really liked about it? What were ways that we could improve kind of the MSK delivery of care, are going to be really important. And so we have the opportunity now to be like, okay, we've done it. We see that there are some diagnoses that really benefit from telehealth services, such as low back pain, complex pain, osteoarthritis, even stroke. People who may not be able to get in and out of their house could still be seen via telehealth services. And so, we can't make it diagnosis specific because there's definitely grades to each diagnosis, but making sure that we have the policies in place that allow people the option of using telehealth and promoting that. So is it doing like extending telehealth services by allowing, maybe some more visits that are like more of a check-in for points of care instead of just like definitive care? It's complicated, but it's really exciting. And there's a lot of work that could be done to really help make sure that people are getting the right care that they need.
And together with all the questions that Dr. Dowler said her department was facing, it's important to underscore those very important opportunities to actually maintain care and improve care. So thank you so much, Catherine, for a great presentation. We're now going to move to our first broad panel focused on telehealth access. Again, telehealth access during COVID-19 for beneficiaries. Sorry, I'm jumping around here as the slides move telehealth access in North Carolina, implications for care delivery. And we're going to be hearing perspectives from Medicaid beneficiaries, from behavioral health and musculoskeletal providers on policies and supports that are needed within the healthcare delivery system to improve equitable access to care via telehealth. We have a number of distinguished panelists. Let me introduce them now. First, we're very happy to have Dr. Steve North, who's Vice President of Medical Operations for Eleanor Health. Next, Mike Schmidt, Director of Payer Relations of the North Carolina Physical Therapy Association and physical therapist at Duke Health. Also, Evie Nicholas, Behavioral Health Program Director at Med North Health Center. And finally, Levisa Escobar Garcia, Project Administrator, Health Lit for Wake, Wake County Health and Human Services Department. So thanks to all of you for joining us today. I want to ask you from your perspectives, you heard what the overall results of this study. Good news, telehealth very much helped many populations maintain access. Bad news, did not do enough, as we might have hoped, to reduce disparities. Again, from your personal perspectives, what are some examples of when telehealth has worked well for particular people and populations, and some examples when telehealth has not worked well for patients or providers? And Dr. North, I'd like to start with you.
Okay, great. So hi, I'm Steve North, and I actually live in a rural community up in the mountains of Western North Carolina and have been here for 16 years. So the barriers to care in rural communities is something I am very familiar with. I think that when we think about successful programs, the most successful program in North Carolina, I believe, is the NC STEP program, delivering behavioral health in emergency departments. And that's really been the hallmark of improving access. And as we think about the factors that came in, it was moving from a grant funding stream into a line item state funding and really having collaboration between multiple large health systems to staff it. When I think about struggling or unsuccessful programs, I think about outside entities that have tried to come into the state and provide care without knowing the landscape of the communities that they're serving, and having that care be disjointed, whether that be an employer insurance funded virtual care platform or a freestanding behavioral health service that has limited understanding of local resources. We've got some great groups in our state doing virtual behavioral health, but they're actually located in the state and have offices and people you can call that know the local resources. Thanks.
So just briefly, what do you think are the implications of that, other than a very important obvious point, which is you need to know your patient population to really deliver optimal care, no matter what the modality of care is? What do you think?
Yeah, so I think that you need to know people. The implication is around quality and continuity, that an entity that comes in from outside or is virtual only may face more scrutiny and not have the longevity. And so people who desperately need access to care are jumping from one place to another and not getting the continuity that is truly going to help them improve. There's also going to be increased cost implications with disjointed care.
Great. Well, thank you. Well, Mike Schmidt, I'd like to go to you next. Again, what are some examples from your perspective of what has worked well in telehealth and what has not worked well in telehealth, particularly during the pandemic?
Yeah, thanks, Susan. I appreciate being here. I would say some of the things that work well, it really, like everyone has said, it depends on the type of condition that the patient's coming in for. It also depends on the type of intervention that's applied, because even from a physical therapy and rehab perspective, the intervention can be primarily education-based or information versus more hands-on treatment, which would be very difficult to deliver through a telehealth platform. And then lastly, I think importantly that we haven't talked about it yet is the interest of the patient. So how much the patient is interested in that type of treatment pathway as well. So I think that we see it work well when the condition, the intervention, and then the interest of the patient matches up for that delivery of care. I'd say that areas where it doesn't work well is what we touched on, if they don't have great access to the delivery of that care. So if there's And also if they're not familiar with how to use it, because we have examples of where providers were working with patients and they spent the entire length of time just getting them set up and used to the system of how to use it, and then schedule a follow-up visit to actually provide the intervention at that point. And so I think those are some of the areas. And one key simple example I can think of something that worked well was a patient, even in an urban setting, that was commonly coming to our clinics, and it was taking them up to an hour and a half to 2 hours to get to the clinic from door to door, even though they were only 20 miles away, because of the transportation issues that led to that point, where we cut down 2 hours of that person's time in order to provide a telehealth visit, which then allows them to go to work and at a better time, or to take their kids to school. And so I think those are some great avenues of where it even works from an urban standpoint as well.
Great. I want to come back to the point you just made about the interest of the patient. Other than some of the factors you mentioned, familiarity with technology and so on, are there other areas of patient interest that could be or should be influenced one way or another around use of telehealth?
Some of it, I think, is it's unique as well to patients. I know that we were previously talking about how the older adult population had a harder time utilizing it. Some of it's because, if you have an older adult that's 90 years old, they've been used to the medical system for 90 years, operating in a way where they go physically to a location to receive that care. So it's a massive change in the way they typically receive that. And so that takes time for any kind of behavior change of how you're utilizing things. And so it's trying to better educate or better inform, and then also give them the opportunity to try it and see how they like it or not for that type of intervention. Does that answer your question?
Yes, indeed. Thanks so much. Thank you. So Evie Nicholas, let's go to you next as Behavioral Health Program Director at Med North Health Center. What have you seen that has worked well or not worked well in telehealth?
Yeah, so Med North is a federally qualified healthcare center. So a lot of our patient population would be what you guys are referencing as kind of like historically marginalized populations. And overall, I think our numbers, and I would be curious to run them after listening to your data. I think it supports increasing services for our patient population. I think a good thing is it got us over the hurdle. I think we were nervous about using telehealth with our populations prior to the pandemic, and this kind of forced our hand. So I think that that's a good thing. I think it's helped a lot with now that the pandemic is kind of shifting. I think it helps, and certainly during the pandemic, it helped a lot with flexibility. So a lot of our patients have last minute life changes, right? With transportation, with childcare, with, different, with somebody in the house being sick. Maybe it's not even the identified patient. And previously those things would have all meant no session, right? Like that we couldn't have helped them. And now we can. Right. And so I think that works really well. So we can switch the visit to telehealth last minute, right? Like, the same day, an hour before, 10 minutes before. And that's huge, especially because Medicaid transportation requires 3-day notice for transportation changes. So if a patient thought they had a ride and then it falls through, now they can come via telehealth, right? We found audio only critical. Both for our Spanish speaking populations, which is about 50% of our patient population, but just anyone and everyone, especially the option even to transition to audio only. So maybe technology was working well and then something happens. Maybe the kids came home and now they're using the data or whatever. So things change. So being able to use audio as we need to is super important for us. It does work better, we think, with existing patients. There's also the barrier of with new patients. I know for behavioral health, we have to have some signatures. So in addition to the telehealth stuff working, you also have to have a virtual signing thing that the patient can access and is working. And for some of our patient populations, that's very tricky. So literacy is an issue, and asking them to read not only like now over an internet platform with and having an email address, and there's other factors and barriers there. So we have found that when the pandemic issue subsided, having new patients come in and doing an in-person session with us and helping kind of mitigate those barriers for the new patient. So, you know, providing additional transportation or doing whatever it took for one time, and then having a conversation with them about telehealth moving forward, if that was better for them. We found that that's been really helpful. We find it continues to be helpful for anybody who's immunocompromised or infection control issues. So especially I work with a lot of patients, and we're applying to be a tailored site. So I hope this is something that is considered, that with individuals with intellectual and developmental disabilities or with certain medical conditions, they may be immunocompromised. So it may be that I have a slight cold or a slight medical issue, or that they do, or that someone else in the house does, and that it would be important for them to not be around a lot of other people right now, right? For their medical risks. Or I have some kind of medical risk or whatever, you know, that I need to be, you know, kept safe from. At one point I was pregnant during the pandemic. So it was really helpful, to consider that as well. I think things that you also need to consider are strained relationships in the home. So if the person doing telehealth has a strained relationship with somebody else in their home, whether there's domestic violence or it's just maybe a strained relationship of any kind, it can be difficult, right? Because they may not feel fully comfortable, even if they're in a private room, to discuss that. So I think setting boundaries has been really important, especially as the pandemic subsided a little bit. We found a lot more people that wanted to do laundry and, you know, go out and do other things, and that that seeing telehealth like an in-person visit was something we needed to discuss more frequently, especially after that period ended. And in general, young kids were really challenging to do behavioral health with over the internet platform. So that's a population we prefer in person, but I think overall our message is you need to have a relationship with your patients and talk to them about the pros and cons of telehealth, and help and let them be a partner in deciding whether it's right for them.
Great. Well, thank you so much. So Luisa Escobar Garcia, to go to you next. You've heard a lot already from your colleagues about what's worked well in their situations and what hasn't. What would you add to what your colleagues have said that represents ongoing nuancing of our understanding of when it is optimal to use telehealth and when it may not be so optimal?
Absolutely. I heard so many echoes of my prepared remarks that it's almost like, what could I add? But I think that I would focus on my perspective and my experience during the first year of the pandemic as a provider of telehealth. And what I saw, you know, kind of echoing a little of what Evie was just saying, was this relief for parents of multiple children to be able to do the work that they would do in their home with the rest of the kids, and supporting that target child and having those co-occurring things around them, but still, like you discussed, creating boundaries so that they could create a space that would be productive for a virtual therapy session, while also allowing that flexibility that they could parent and feed and attend to, you know, and cover all those bases. So I think it was a really big strength and tool to have, but only after certain foundational items were met. So we needed to first have someone in person. I think like one of, sorry, I'm not sure if it was Mike or Steve that mentioned, you know, how important it was to have that in-person access. You need to have someone that can come by and do that initial assessment and support them in whatever needs they may have. And once they are set up and have those that assessment ready, then the clinician can come in and really take advantage, and I think have higher rates of engagement.
So it really is a function of continuing to tinker with our care delivery model. We have to assume also the payment model, because people who would come into the home to provide the kind of assistance that you're talking about would need to be paid to do that. As you think about putting those kinds of systems together and think about the very important role that all of this presentation, all of this project has underscored, We need to do all of this in a way to drive down disparities in care, not increase the disparities in access to care. What would you think would be some of the most innovative ways to go about doing that?
Absolutely. So what, as I was listening, and one of the first things I thought of was language access. So my main work in the past year was with the Latinx community in Wake County, and it was an enormous change or ability and take up for service engagement and people to receive what was being offered if it was both linguistically and culturally competent. And that, I think, requires insight into not just having available practitioners that are fluent in the language being offered, whether it is because we have a variety of immigrant populations here in the county. And so making sure that we're actually covering, what are the highest, the largest groups, and can we get people that speak every one of those languages, but then also looking into the different subgroups within those groups and finding competency to meet all of those different needs. Because, for example, in the Latinx community, the Mexican population in Wake County may have different needs and a different style of approach for a clinician than might have the Dominican population in Wake County. And so I think having clinicians that have that awareness and then the capacity to tailor their services to that will be critically important. And in addition to that, I thought audio only was going to be huge, especially with the behavioral work, because when we want to do the collaterals with parents. So if you're working with a teenager, yes, it might be difficult to engage them, to get them on screen. So that's an entirely different process. But when you want to do a collateral, especially with a Latina mother, the easiest and best way that she is going to be able to kind of engage and be present and hear how she can best support her child or the parent, and they can best support their child, is going to be through that audio only collateral. And sometimes there were challenges in policy as to whether or not the clinician could bill for audio only, because telehealth was specifically for video and audio. And so I think that removing those barriers and creating, a 15-minute phone call option, a 30-minute audio visit option, and just incorporating that into the written policy, and then the ability to bill for it will be the critical key in creating that access of really meeting the community where they're at.
And underscoring again, another very important finding from this overall project, which is how important audio was for certain populations and how important it would be to continue to have that going forward. Recognizing that, as Dr. Dowler said, there will be program integrity challenges in that, but nonetheless, if it's an effective modality of care, it probably ought to be continued. So I want to take this question of disparities back to Evie, to Mike, and to Steve, because again, thinking about the disparities, particularly the ones that have been most evident in your populations, the populations of patients that you served, what do you think is the best route forward to address those? Steve, particularly with respect to telehealth in rural areas. Obviously, better broadband access in those areas is going to help. What else would be extremely important if we really are serious in helping populations in rural areas avail themselves of this important care modality?
So yes, broadband. It's both an urban and a rural issue. So we can't assume that just because you live in downtown Raleigh, you have great access. I think we need to really be looking at how we can expand the use of telehealth and the definition to meet people where they are, as other people have said. And when we think about doing that, where are first alternative access points? I think that one of the roles I have is being medical director for an 11-county rural school-based telemedicine program that's been around since 2011. So that's one place, but also I think volunteer fire departments have a huge amount of potential. They're in every community. Most of the time people know who's there. and the volunteer firemen and first responders are prepared to do vital signs and present. So the opportunity to expand beyond just a video only visit is there. We also need to look at sort of, what are we thinking about? Is it just telehealth, this sort of actual synchronous encounter, or can we expand more into the realm of virtual care with asynchronous engagement through digital therapeutics and other platforms, remote home monitoring? How do we get home health engaged? I think one of the biggest challenges is rural medical providers, while we embrace it, and I know Karen Smith will be on later, the opportunity, implementation is tough. It is not just about setting up a Zoom link. Working it into your day-to-day practice is difficult. And then thinking about expanding into other aspects of care, there's a cost involved to set up a remote home monitoring program, or to be available to see people at a community center in an old church somewhere else. So those are some aspects for increasing engagement in rural communities.
There's a lot of opportunity for innovation, as you suggest, and taking advantage of people who are already there in the communities, as you say, Steve. Thank you so much for that. So Evie, I want to ask you the same question. As we think about driving out disparities in care use and access via telehealth, what would be the most important strategies that you see?
I mean, I think overall we have to be flexible and adaptable. I mean, I think is what I see. Like, I think it's easy to compare what a best case scenario we think looks like as compared to what, right? So if a patient is not going to engage, right, and this is an engagement at maybe at a level 4 versus a level 0, like that's still better than maybe like your top-notch thing that might be a level 10, right? But if they were never going to go there, if they never were going to do it, right, a 4 is better than a 0, right? And I feel like sometimes we miss that. I feel like sometimes we're like, yeah, but we got to go for the 10. And it's like, yeah, but the 10 wasn't ever happening. It wasn't happening, right? Like it wasn't working. So I feel
and
like
it gives them,
yeah.
so sorry, Evie. No, it gives them the opportunity to scale from there.
Yes.
If that patient who was never going to walk into your facility has 2, 3, 4 months to build trust at that lower level of engagement, and then eventually decides, because that clinician is well compensated and is consistent and is still there, perhaps in 6 months they can keep going with the service and be at that higher level that we're hoping for.
Yes. That exactly what she said. Like, I really feel strongly about that, right? Is that sometimes we just are not willing to look at what it takes to get there. And I think that we saw a lot of that, right? And we saw, and I really see that with my IDD populations and my, like those types of populations too. Like if they're comfortable with a phone call, we need to start with a phone call because that's what they're comfortable with, right? And then we can move up. But to say, I've got to see you 4 times in a month, or it doesn't meet the standard of care, well, then everybody's set up for failure. The provider, the patient, like, and nobody gets help. Right. And it's just a setup, or it's a setup for just a false encounter where you just like saw them in the parking lot or something, and you're not really doing anything meaningful anyway. Right. So I think we need to be open, and look at that. And I do think we do need support staff to help with technology setup. So we have really needed our front desk, or what we call our patient access team, to help with like, hey, can you sit there for 30 minutes and problem solve how to get on Zoom so that I don't have to spend my time to do that. And that's been really helpful.
Great. Thank you so much, Evie. And I'm going to give the last word to you, Mike, on this question. But again, speaking from your vantage point in the MSK world, what additional flexibilities, innovation, et cetera, would really accomplish a decrease in the disparities that we've identified through this study and that you all have been speaking about earlier?
Yeah, thanks, Susan. Yeah, I think one thing that we've really noticed here, especially being at Duke, so at Duke, we are extremely privileged as far as the resources that we have available to provide telehealth services. So during this time when we were incorporating telehealth services, we had people available to call patients before the clinician even met with the patient, to get them on board, used to the system, and educating them of how to using it. We also have interpreter services available for patients that speak pretty much any language in the world in order to be on the call with us. Or to have access to them through iPads or phones or things of that nature. So those made our life a whole lot easier, it sounds like, compared to some of you all and some of the issues that you were dealing with. But I would echo Steve's point as far as, broadband is highly important and we need to have access to that. But even especially with this patient population, just because they have access to broadband doesn't mean they have the equipment or other additional resources to be able to use that. So having sites available can be very helpful. I know, for example, like our veterans at the VA system, they get access to tablets that are sent to them. And I'm not saying that we should give tablets to everyone in the entire world, but they then have the resources sent to them to be able to utilize that service at a much better level. But if we had specific sites around communities, that could help to improve that access.
Well, again, you all have made these wonderful points about the importance of building on capabilities that already exist, knowing one's patient population, taking advantage of people already in the community and thinking of new ways to link individuals with services and supports and technologies, all of which represents an enormous and exciting, frankly, set of opportunities to take advantage of the capabilities inherent in telehealth, as we've been talking about over the course of this morning. So I want to thank all of you, Louisa, Evie, Steve, and Mike, for a terrific discussion. And now to take the lead on our next panel, I'm going to turn things back over to my colleague, Dr. Rebecca Whitaker. So Rebecca, please take it away.
All right, thank you, Susan. So for the second panel today, we're going to be talking about the role of health plans and policymakers in supporting telehealth access. So our distinguished panelists are outlined here on this slide. We have Corey Dunn, the Director of Public Policy with Disability Rights, North Carolina. Jenny Whitman, a Public Policy Manager with the Alliance for Community Health Plans. Angie Bailey, the Director of the Broadband Infrastructure Office at the North Carolina Department of Information Technology's Division of Broadband and Digital Equity. And last and certainly not least, we have Dr. Karen Smith, a family physician and board member of the American Academy of Family Physicians. So thank you all for being here today. I am going to direct my first question to you, Corey. We just heard some findings about where telehealth is falling short of providing equitable access to care for certain groups. So how are you thinking about equitable access to care for individuals with disabilities, and how can telehealth either help or harm that?
Thanks, Rebecca. And I've been really encouraged by what I've heard so far from providers and others today, the level of kind of awareness of these concerns already, and how much folks have grappled with it and come up with creative solutions. I want to make sure that people with disabilities are both given all the access that they need and want to telehealth, but also not pushed into telehealth in a way that is primarily for the convenience of payors and providers as opposed to patients. And so I want to make sure that we're considering things like, is the technology that we're relying on accessible, right? Do you know how to make sure that hard of hearing patients are able to communicate effectively with you, because providing effective communication is an obligation of healthcare providers. So there are those kinds of technical accessibility questions. Then there are the technological questions that folks have raised. You know, for someone who is has low vision, a phone screen might not be big enough, right? You really might need something bigger for them to meaningfully interact with a healthcare provider. And likewise, the previous panelists talked a lot about the effectiveness of telemed or telehealth with young children. There are going to be some setups that are more effective and accessible for people for whom sitting still for whatever reason, whether because you're 3 or because it makes you deeply uncomfortable to sit in front of a camera and sit still and sort of falsely make eye contact with the little dot at the top of your screen. Whatever the reason, we want to make sure that we're creating the setups that are most accessible to the people who need and want the care. On the other side, we want to make sure that people aren't being pushed into telehealth because transportation's too expensive, or because of some other sort of systemic barrier that's not of their making, not of the making of the patient.
Great. I think those are really critical points, and I appreciate you kind of raising the trade-off there. Dr. Smith, I wanted to come to you next. If you could share a little bit about how your practice is currently using telehealth and how you're thinking about telehealth and your care delivery model going forward. Where would some additional policy reforms be helpful?
Very good. Thank you so much for allowing me to participate. I am an independent physician in rural Rayford, North Carolina. And I want to say hats off to Kareem, because one of the things that we noted, we have to put the patient back in the driver's seat in terms of their care and how the care is not only being delivered, but received. And so we've utilized the telehealth to leverage our services for like chronic care management, those individuals who have chronic diseases like hypertension, diabetes, and what's going on with them in the home setting, in their work setting, because it's more than just staying home to receive those services. We started off with telehealth with the substance use disorders, with the opiate use disorder, and providing buprenorphine therapy for those individuals who were opiate addicted. And so we started telehealth before the pandemic. I appreciated the data that was shared. And that, yes, those who were already used to it a year before the pandemic continued to use it. And it was more or less introducing it to those who had chronic care needs that a challenge became, because it was, frankly, it was new to them. So that's what we're using it in our setting. We're going to continue to move it forward. And we'll talk a little bit more about some of the nuances and challenges and how do we move it forward.
Great, thank you. Jenny, if I could come to you next, I'm curious kind of what you're seeing from health plans who are testing out different ways to increase access to care via telehealth. I know we've heard some examples of Medicare Advantage plans, for example, leveraging their supplemental benefits to help pay for internet connections, for example. So what are you seeing nationally across health plans?
Yeah, I think so I'll just first caveat my remarks and say that I do national level policy, so I don't necessarily dig on a state by state level. So bear with me here as I sort of bring it up to the national level. But I think generally we're seeing massive shifts towards policy making that is enabling broader access to telehealth services. But from a plan perspective, they're really leaning into the current flexibilities that they already have. Rebecca, as you noticed, or as you mentioned in Medicare Advantage, they have supplemental benefits. But not only that, they now have these things called additional telehealth benefits. And so this is really allowing these Medicare Advantage organizations to fully integrate virtual care within patient standard care products for their insurance. And so that's a really, really interesting thing. We are also seeing that on the private commercial side of the payer world as well, right? So and a soaring emergence of virtual first products, which I think is a really essential thing, particularly as we consider what's going to happen when the public health emergency ends and Medicaid eligibility starts to see some shifts, right? And so now there are going to be these virtual first products that are in the marketplace, that are more affordable, and that allow patients to have a virtual first front door into the healthcare system that maybe is a bit of an easier transition for them than a dramatic shift to, a standard and heavy, intense sort of traditional care plan that might be a bit intimidating for them to sign up for. So those sort of national level shifts and changes are going to be really great, but we also see, sort of more community level investments as well from a telehealth standpoint. We're seeing plans considering things like investing in hotspots for their community. They're doing really targeted approaches for virtual care, particularly in the prenatal and in the prenatal care, space. Things like nutrition assistance programs, right? So they'll use virtual care services to make sure that patients are finding their way to specific social need referral programs. And so that in particular is really finding its foothold within the payer world, but also just the virtual care world in general.
Yeah, that's super interesting. And your last remark about, using telehealth to better link to social services as well. I think that's an interesting model that we haven't touched on much today. So I appreciate you raising that. Angie, if I could turn to you next, and if you could share with us sort of what is, maybe define for us kind of what is digital equity and how is the Office of Broadband Infrastructure thinking of leveraging the various federal funding streams and other state resources to help advance digital equity in the state?
Sure. Well, thank you for having me. We've been so focused on infrastructure deployment in the past recent months, and to hear and really talk about the utilization and why this infrastructure is so important is really helpful and interesting. So thank you. So the broadband. So spring of 2021, Congress passed the American Rescue Plan Act. And then in December, our state legislature appropriated $1 billion to our Division of Broadband and Digital Equity, which is part of our North Carolina Department of IT. And so almost $1 billion of that will be going towards broadband infrastructure deployments and about $50 million for digital equity work. So we are really in an unprecedented time. In comparison, our typical recurring grant program has been at $50 million a year for building out last mile. So there's a lot going on in the space. Digital equity, of course, is the goal that we're working towards, right? So that would be that everyone has full participation, has full IT capacity to participate in society and in the economy. So that's where we want to be. And digital equity is needed, right, for full participation in education and workforce and health, telehealth, and other services. And so that's the goal. Within that, we look at digital inclusion activities as being kind of the strategies that we need to get there. So I know we've already touched on most of these today, but obviously having broadband internet access, whether it's at your household or at a community center near you. And that's something that my office is working hard on. But making sure that it's affordable, that's a huge issue, one that I don't think will be easily solved. There is a federal affordable connectivity program through the FCC that has been launched that is receiving money from the Infrastructure Investment and Jobs Act. That's $14 billion. And that's a subsidy of $30 a month for low-income households. So, the connectivity, affordability, access to devices. What else? Digital literacy training, of course, is key. And I think within the telehealth space, it's basic digital literacy, but then also, literacy around whatever your devices are that you're using for telehealth. And so those are some of the key issues. And so addressing all those pieces, I think there's different solutions for different pieces. So it's important, but I do think that we're moving forward. There's obviously a lot of attention on the topic. The other thing I think I meant to say is tech support. And so to me, that's tech support for the patients themselves. It's really important. There's a lot of focus around digital navigator programs and having people that you can access to help you walk you through support for these applications. And then also, I think was mentioned support for the actual healthcare providers, who at this doctor's office is really going to deal with getting this application up and running. And so that's really important as well.
That's great. I think that the notion of a digital navigator and maybe integrating that into some of our community-based roles, like the community health worker role, and kind of facilitating access to care more broadly, both in person and remotely using telehealth is exciting. Yeah, thank you for covering that.
Thank you.
Covering that. My next question is I'm going to pose to both Dr. Smith and Jenny here, and maybe I'll let you answer first, Jenny. But a lot of folks, both nationally and in North Carolina, are worried about the cost associated with broad telehealth policies, and certain questions about the quality of care received via telehealth too, that we touched on a lot earlier. So how can value-based payment models help facilitate effective delivery of healthcare services via telehealth, and making sure those are high-value services that can keep costs down?
Yeah, no, this is a great question. So thank you for raising it. I will just note that this week, a really important study came out speaking to this question specifically, not so much the value-based care component, but the concerns about telehealth causing an increase of utilization and therefore costs. And so a study in JAMA just came out sort of indicating that that's not necessarily the case. And so I think two things are going to have to happen. In the interim, we're going to need more studies like that. And they're growing in number. I think many of us can probably remember pre-pandemic doing all of our research and trying to identify precedents for telehealth in this policy space. There were limited studies out there, and we're seeing just exponential growth in that space. And so I think that's really important. But then the next piece of that is being able to say, okay, policymakers, both on state and national levels, here's the proof. And by the way, why don't we just go ahead and incorporate this into value-based payment models? And so, I think you'll see in integrated systems, particularly on the payer side, there's already examples of them doing this, right? And that's in a couple different models: salaried physicians, value-based payment arrangements, global capitation, those kinds of things. But ACHP actually took it a step further, recognizing that in order to really shift this conversation to value-based payment within telehealth, we needed to present a couple case studies to the world. And so we did a white paper that put forward potential value-based payment arrangements that could be adopted that would allow you to incorporate virtual care more inclusively, that wasn't sort of making providers dictate things based on items, services, remote patient monitoring, asynchronous versus synchronous telehealth care, those kinds of things. And so we're really hoping that sort of sets the foundation for the conversation for policymakers moving forward, getting them to start wrapping their heads around how can we do this on a national level.
Yeah, turning to you next, Dr. Smith. This idea
Very
of
good.
telehealth. Yeah.
So it was an excellent discussion in terms of what we know of as a blended payment model. And part of the issue that we're having right now is many of us are transitioning from the fee-for-service, or that unit-based payment for services provided, and moving more towards a comprehensive care delivery system. And we find ourselves kind of in the middle right now. So how do we approach this? Well, what are the expectations? What are the expectations of the provider of care, the physician who's providing those services? What about the patient? And what about the payers? What are the expectations that are desired in order to meet the outcomes that we're all looking forward to? And I think that's where some of the issue lies right now, is that we really haven't been able to come up with that magical combination that's going to work well, that's going to allow us to provide those services within the value-based payment model. For example, we know a lot of our ACO work is successful because we're focusing on transitional care visits, ED utilizations, annual wellness visits, and all of those are access points. But we don't see the desired outcome just from a single component, but it's a mixture of it, and it's a blended form of it. And that's where telehealth fits in well. One other point that I was going to say along the disparities line, telehealth is addressing, yes, it allows a physician to have a connection with the patient. And it's not just that of access, it's that trusting relationship that was developed. the same trusting relationship that allows us to be successful in a value-based payment model. And so there's a lot more that we're shifting to, that we're understanding, but it's not just access, it's not just technology, it's all a combination that fits into that value-based payment model frame of thinking.
I'll add one other comment if I could. And I just think this is important too when we're thinking about telehealth in the future, not just in the next year or so, but really in the next 5 to 10 years. I believe it was Dr. North who said this in his remarks earlier, was the need for full integration of telehealth within the care delivery system and the patient care pathway. And that's a really important component too, because we need to start moving away from fragmented care, particularly in the virtual space. And one of the ways and the easiest ways to assist that process is with value-based payment arrangements, because when you stop paying for things and specific ancillary services, and you start thinking about it in terms of integrated care, that shift becomes easier, right? Providers are now rewarded for full care integration, regardless of how the patient received those services and what platform they used. So we really need to start thinking about how can the industry as a whole really start integrating virtual care services, and we'll get to that point. My belief is we'll get to that point through value-based payment.
Yeah, all great points. And this idea around setting expectations for the integration of telehealth into kind of longitudinal care management and patient pathways, and how can value-based payment facilitate that, as well as sort of this approach to reducing health disparities that you were making, the point you were making, Dr. Smith. So appreciate those points. Corey, turning to you next. So what should payers and policymakers be thinking about in terms of designing long-term coverage policies for telehealth that meet the needs of individuals with disabilities in North Carolina? And how should they be thinking about evaluating the quality of services from a beneficiary perspective?
Thanks, Rebecca. I really appreciate thinking about the quality question from the beneficiary perspective, especially because if we look at it just in terms of like long-term payment or long-term cost containment, we really miss out on some of the best parts of telehealth, which are you can, in some cases, see a fuller picture of a person's life, their home environment, their behavior, not in a tiny 8 by 12 room with a paper gown on. You can really get a fuller picture of someone's humanity and how their need for healthcare fits into their life. And so I really want to make sure that as we're designing value-based payment systems, which I agree are where we're headed, that some of the things we are measuring and paying for are really about not just, reducing hospital admissions or, some of the traditional value-based payment measures, but also, does a person with a disability self-assess that they are able to more fully engage in their home, their family, their community because of the care that they're getting? And those things are harder to measure, right? And they're not going to be reduced to encounter data. They are they're messier, and I think in a lot of cases are going to be only really measurable in the aggregate, not based on one patient's experience, but based on a provider's sort of broader track record, so that we will incentivize the creation and expansion of providers who are doing this right. Because we all know that you can do telemed badly. That's easy enough. But the folks who excel at it and who really use this modality to creatively and in a way that helps them serve their patients better, we're going to need to learn from them because we are all still so actively learning in this space, and we're going to need to replicate those practices. We don't even know what those practices are enough to incentivize them now. So we've got to figure out what the long-term benefits are, figure out what caused those. Bless you, data folks. That thankfully is not my job. And then figure out how to replicate it. And so that might mean for one person, that might mean, or for one practice area, that might mean, for example, getting a video tour of your patient's home to determine occupational therapy opportunities and needs. It might include, for a dietitian, it might include like, okay, let's talk about your refrigerator. let's talk about what's in there and what could be in there, and the kind of high touch opportunities that telehealth creates, that as opposed to just what we're losing in telehealth, right? We do lose some stuff, and we need to mitigate against that with home health visits and in-person visits as appropriate per modality. But we also really have to maximize what's possible with telehealth that's never going to be possible in the provider's office. And measuring those kinds of things, incentivizing those kinds of things, I think is going to have a really meaningful impact on the lives of people with disabilities who have been seen as an abstraction in a clinical setting forever, right? It's a new way of approaching care, not just a new toy.
Yeah, no, thank you. And I hear that, the point certainly around a lot of research yet to come, and keeping the beneficiary at the center. Jenny, you wanted to make a quick comment.
Yeah, so I just think this is kind of underlying all of the comments, particularly around improving access, reducing disparities, and addressing and measuring appropriate quality metrics, right, within this telehealth space, is that we fundamentally don't have a national or universal standard to collect race, ethnicity, language, disability status, and those sorts of things. So in order for us to really make gains in this space, we need the administration to really step in, fill that role, help the industry identify those standards, and then we can make so much more progress when we do the research, when we make these policy changes, when we modify our benefit products in order to meet beneficiary needs better. So that to me is like a fundamental policy, implication that really needs to happen very quickly.
Great, thank you. I think, I'm going to direct our last question here to Dr. Smith and you, Angie. And that is, given what we've heard today about access to healthcare and barriers to using telehealth, but also interest in using telehealth, both from the provider community, but as well as the beneficiary community, what is your one wish for what you would like to see over the coming months from the state or federal level to support equitable access to care using telehealth? And I might add on to that for you, Angie, sort of how can payers, providers, consumers get involved in the work that you all are doing? So Dr. Smith, maybe I'll go to you first. So, what's your one wish for what you would like to see?
Very good. My wish is not to be focused on access. Pay attention to the policies that are being thought of and created, and make sure that we listen to the patient stories, that we get their insight, that we test out our ideas before we implement it. It's not always just access. There's so many other factors that are playing a role in disparities. And if we get focused on just providing access, we're going to miss it. We're going to miss a golden opportunity to actually enhance the type of care that people desire and the care that we're attempting to deliver.
Yeah, that's really critical. It's just the starting point. It's not you're not solving anything in and of itself. Appreciate that point. And Angie, turning to you. So what's your one wish for what you'd like to see for the state or federal level to support?
So I think, so next Friday, the National Telecommunications and Information Administration will be releasing rules, their notice of funding for some new pots of money under the Infrastructure Investment and Jobs Act. So one of those is a pot for digital equity work. And part of that will be a digital equity plan for the state. And so I think, you know, within that plan is the opportunity to have a more comprehensive telehealth to capture. I mean, I would love for us to, so, you know, we expect that funding to come through our division to be able to capture lessons learned and how, with all the folks involved in this space, how can we really capture what's the key lessons, and how can we make sure that with this opportunity we have, I know funding is not the only answer and there's lots of pieces involved, but with the funding that we do have, how can we really make sure we use it for to move forward with this topic and capture what's needed, but with our partners. So and I think convening this group is really an important step towards that, right? To make sure folks are talking, and we as an office would like to be more engaged and need to be more engaged, I think, as well.
Well, we will definitely keep you said next Friday. We will keep an eye out for that, certainly.
Yes.
Yeah, appreciate that. Well, thank you all for your participation in today's event, and a special thanks to our wonderful panelists who provided, you know, unique insight into strategies and policies to ensure that telehealth creates more opportunities for all people to access the healthcare services they need, when and how they need those services. To summarize some of the key points that we heard today, you know, we certainly still have a lot of work to do and a lot of questions that need to be answered with respect to integrating telehealth into our care delivery models and into our payment models. And we know we need to do this in a way that drives down disparities in access to care. But to Dr. Smith's point, it's not just enough to focus on access to care. You know, our research showed us that people who are Black are less likely to use telehealth to access behavioral health services, and a lower proportion of Black beneficiaries use telehealth to access musculoskeletal services. But we also know that telehealth can be a critical way for people who are eligible for the tailored plans in our state to access healthcare. And equitable access to care should mean that people have an option to choose telehealth or in-person care, that we can meet people sort of where they are. We have work to do to address the digital divide and digital equity with better access to broadband and the technology needed to access services using telehealth. And there are federal grants to help support these efforts. So we hope you can take away important research findings from today's events, but also practical next steps for improving access to care using telehealth and ultimately patient outcomes. A special thanks again to the KP Reynolds Charitable Trust for the support of this work. Without it, we would not have these important findings and this great discussion that we've had today. We'd like to say thanks Susan Denser for moderation of this virtual town hall, the Duke Margolis Center for hosting today's event, and our dedicated interdisciplinary research team for helping put together the research part of the event today, as well as Luke DeRocher, Duke Margolis's events and marketing manager, for helping us put on the event today. So thank you all for attending, and I hope you stay well.